So when we talk about gastrin, this is a substance related to the stomach, a hormone produced by the G cells in the stomach. Here you can see the G cells in the stomach. They're mainly located in this pyloric antrum. The main job of these G cells is to stimulate the stomach to produce hydrochloric acid. And how this basically happens is that it basically stimulates the parietal cells and this increases the hydrochloric acid secretion. You have the parietal cells here, and this increases the hydrochloric acid secretion. It also increases gastric motility and it stimulates growth of the gastric mucosa. So, this growth of gastric mucosa also increases all due to G cells. And then it also activates enterochromaffin cells. The enterochromaffin like cells, the ECL cells, release histamine, and that leads to more acid. So whenever gastrin is released, whenever food enters the stomach, you have proteins or amino acids that are present in the food. This stretches the stomach, and there's vagus nerve stimulation. When there's vagus nerve stimulation, you have the GRP involved here. Whenever food enters the stomach and the protein or amino acids that are present in the stomach stretch the stomach, there's vagus nerve stimulation through the GRP, which is your gastrin releasing peptide or acetylcholine. Now, this GRP or acetylcholine acts on the G cells and releases gastrin. Gastrin then causes enterochromaffin cells to create histamine, and this histamine then leads to the parietal cells, which create more hydrochloric acid. So basically, gastrin is your peptide hormone, which is secreted by the G cells of the pyloric antrum of the stomach and stimulates gastric acid secretion and gastric mucosal growth. Now we have something called as a Zollinger-Ellison syndrome. Now we have a condition called the Zollinger-Ellison syndrome. It's a condition where there's a tumor called a gastrinoma, and this secretes excessive gastrin. This leads to massive gastric production and severe peptic ulcers. So in the Zollinger-Ellison syndrome, basically in the ZES, you see a gastrin secreting tumor, and this will have basically the gastrin hypersecretions. They have a stimulatory and trophic effect on the parietal cells and the enterochromaffin cells. This leads to extreme acid secretion, and that leads to recurrent or refractory peptic ulcers. So you have multiple refractory ulcers that are refractory to the medical treatments, and they're at unusual places like the jejunum. Now the gastrinoma triangle, basically, you have a triad of the cystic duct. The boundaries of the gastrinoma triangle go up till the cystic duct or the second or third part of the duodenum and the neck of pancreas. So most tumors are found in the duodenum. So 60 to 70% of tumors are found in the duodenum and 20 to 30% tumors are found in the pancreas. So basically, a gastrinoma tumor forms, large amounts of gastrin are produced, and the gastrin stimulates the enterochromaffin cells. The enterochromaffin cells release histamine, and the histamine stimulates parietal cells, and this massive hydrochloric acid secretion. The result is an extremely acidic stomach and multiple aggressive ulcers. So the classic triad is multiple peptic ulcers, severe diarrhea, ulcers in unusual locations, and why that diarrhea occurs is basically the excess acid inactivates the pancreatic enzyme. This damages the intestinal mucosa and this causes fat malabsorption. So you have a special kind of diarrhea where there's steatorrhea present because of the fat malabsorption. Typical symptoms are like severe epigastric pain, recurrent peptic ulcer, GERD symptoms, chronic diarrhea, and weight loss. This ulcer often occurs in duodenum or jejunum. Jejunum is an unusual location, but this is also an important clue when it comes to Zollinger-Ellison syndrome. About 25% of cases of Zollinger-Ellison syndrome are associated with MEN1 mutation, the multiple endocrine neoplasia type 1 mutation. So MEN1 includes tumors of parathyroid, pancreatic endocrine tumors, and pituitary. That is something you diagnose by getting a fasting gastrin level, and this is usually more than 1000 picogram per milliliter, and you get a secretin stimulatory test, and then you get a CT or MRI scan for tumor localization. That's your Zollinger-Ellison syndrome. Now, we have a condition called the chronic atrophic gastritis, which is a long-standing inflammation of the stomach that causes loss or atrophy of gastric glands, loss of parietal cells, and reduced gastric acid secretion. The stomach mucosa, with time, becomes thin and atrophic. Now, there are different types of gastritis. We have a type A autoimmune gastritis. We have a type B gastritis, which is usually due to H. pylori infection. Now we have two types of chronic gastritis. There's a type A autoimmune mediated chronic gastritis, which is autoimmune destruction of the parietal cells. So the parietal cells are basically destroyed through autoimmune processes, and this is mainly located in the body and the fundus of the stomach. The other type is the H. pylori infection induced atrophic gastritis. In here, we have the H. pylori infection causing more of the antrum related um, gastritis. So this usually happens in the antrum. This is antrum gastritis. Okay. And what happens is there's something called as pernicious anemia. Now, the pernicious anemia occurs in type A autoimmune mediated chronic gastritis. I'll now tell you what pernicious anemia is. Pernicious anemia is basically a special kind of anemia where there's a megaloblastic anemia caused by vitamin B12 deficiency. This is due to lack of intrinsic factor. Now, intrinsic factors, healthy specialized stomach cells make intrinsic factor. This is necessary for B12 absorption in the terminal ileum. So, in the terminal ileum, the B12 enters the bloodstream through the usage of intrinsic factor. The blue ones are intrinsic factor, the yellow one is B12. So, the yellow and blue one combine for the B12 to enter the bloodstream. Now, if you have gastritis, autoimmune mediated gastritis, the intrinsic factor cannot be absorbed. Now, since the intrinsic factor cannot be absorbed, this leads to a B12 deficiency. And what happens is, since you have a reduced hydrochloric acid, because the parietal cells normally produce hydrochloric acid, this is reduced because in autoimmune gastritis, these parietal cells are destroyed, and also the intrinsic factor is reduced. So there's a B12 deficiency, and because of the compensatory mechanism of the body, the gastrin is increased because the body thinks there's no acid, so it keeps on releasing more and more gastrin. And the consequences of vitamin B12 deficiency are seen in ways of megaloblastic anemia. You have really large RBCs and you have hypersegmented neutrophils because vitamin B12 is needed for DNA synthesis, red blood cell maturation, and myelin formation. Since you don't have myelin formation here, you have peripheral neuropathy, loss of vibration sensation, and subacute combined degeneration of spinal cord. Remember that folate deficiency does not cause neurological symptoms, only the B12 deficiency causes it. Okay. Now we're going to talk about the ghrelin hormone, which is released mainly from the stomach and most importantly from the fundus area of the stomach. This is a peptide hormone released mainly from the stomach, especially the fundus. The main role is to stimulate hunger and increased appetite. Because of this, it's called the hunger hormone. Smaller amounts also come from some parts of small intestine, pancreas, and hypothalamus. The hormone is released, this ghrelin hormone is released by endocrine cells, P or D1 cells of the gastric mucosa. The ghrelin's function is to act on the hypothalamus in the brain. It stimulates neurons in the arcuate nucleus that increase hunger. Let's go ahead and look at the arcuate nucleus. So you have this hypothalamic arcuate nucleus. The ghrelin works on the arcuate nucleus and that increases hunger. The effects would be to increase appetite, stimulate food intake, promote fat storage, and stimulate growth hormone release. All right, that's all of what ghrelin does. Leptin is the opposite thing. Now, there's a ghrelin and hunger cycle. So, whenever you're hungry, ghrelin is stimulated and leptin is suppressed. During fasting, ghrelin levels increase. This signals the brain to eat, and after eating, ghrelin levels decrease. This suppresses. This basically helps to signal satiety to the brain that you're full. Now, there's something called as the gastric bypass surgery. Now, ghrelin is a hormone that sends hunger signals to the brain. It's produced mainly by the cells in the stomach. Most ghrelin producing cells are located in the fundus part of the stomach. Sleeve gastrectomy removes much of the stomach with its ghrelin producing cells. So, after this bypass, people eat less because stomach capacity is smaller and less ghrelin is released. Now, there's something also called as a Prader-Willi syndrome. This is when patients have very high ghrelin levels and they eat because of severe hunger, hyperphagia, and they have an uncontrollable appetite, and this leads to obesity in this patient. Somatostatin is released from D cells located in pancreatic islets, GI mucosa, stomach, and intestine. It locally acts as a paracrine hormone in the GI tract and also endocrinely from the pancreas. The core concept is that somatostatin mainly slows down digestion. It's a statin, so you can remember it stops many things. The major actions include that it decreases gastric acid secretion, it inhibits the gastrin release, and directly suppresses parietal cells. Here you can see the parietal cell on the left and the D cell on the right. The parietal cells are located in the stomach glands, which include the fundus and body, and they function by secreting the hydrochloric acid. So the parietal cells basically present in the fundus and body secrete hydrochloric acid, and the D cells basically are located in the gastric mucosa, especially the antrum part, and they function by secreting somatostatin. This is an inhibitory hormone. Now, histamine stimulates acid secretion. This histamine stimulates acid secretion. What happens is this blue dot basically represents histamine, and histamine is released from the endochromaffin-like cells, and it binds to H2 receptors on parietal cells. Now, this binding of the histamine to the H2 receptor increases the CAMP, and this activates hydrogen potassium ATPase pump. And this leads to hydrogen ions being pumped into the stomach lumen, and there's increased gastric acid secretion. This is why H2 blockers work, because H2 blockers stop this. And H2 blocker examples are like cimetidine, ranitidine, formatidine. They block the H2 receptor and they reduce acid secretion. Now, somatostatin is released from the D cells. It binds to another receptor called the SST receptor on the parietal cells. So the receptor on the parietal cell basically is coupled to the GI protein. This GI protein inhibits adenylate cyclase and reduces CAMP. Because histamine requires CAMP to stimulate acid secretion, decreasing the CAMP by blocking the SST receptor, which is coupled to GI protein, leads to acid secretion decreases. So acid secretion is decreased. Now there's another effect on the proton pump. The red pump in the diagram, as you can see, represents the hydrogen potassium ATPase pump, this red pump. When somatostatin acts, histamine signaling is suppressed, proton pump activity decreases, and less hydrogen is secreted, which results in gastric acidity being reduced. So it's like a feedback mechanism. Somatostatin acts as a negative feedback regulator. D cells detect acidity. D cells release somatostatin. It inhibits parietal cells, reduces the acid. It goes onto the G cells. Gastrin release is less. Enterochromaffin cells produce less histamine. So it shuts down all stimulatory pathways. What happens in Zollinger-Ellison syndrome is that the somatostatin analogs can be used. Why? Because in Zollinger-Ellison syndrome, the gastrinoma is because of a lot of gastrin being produced, and there's a lot of histamine being produced from enterochromaffin cells, which leads to massive acid secretion. So you can give somatostatin analogs like octreotide and treat Zollinger-Ellison syndrome. Another thing is H. pylori infection. In H. pylori infection, what happens is these D cells are damaged, and so somatostatin is decreased, and therefore gastrin and acid secretion are increased. So this contributes to duodenal ulcers. There are some other effects of somatostatin mentioned in the book, and this include decreased pancreatic and small intestine fluid secretion. Basically, it suppresses this secretion, which results in reduced digestive activity. Then it also decreases gallbladder contraction, which again slows fat digestion. And then it also decreases insulin and glucagon release from the pancreatic islets. It reduces the insulin through beta cells and decreases glucagon through alpha cells. So it regulates endocrine pancreatic activity also. This regulation is stimulated by the acid in the stomach. There's a low pH drives the D cells to release somatostatin. A low pH means a very acidic environment, so it drives the D cells to release somatostatin. This creates a negative feedback, and this also protects the stomach from excessive acid. Remember that it's the D cells, the somatostatin release is inhibited by vagal stimulation. Okay, during the cephalic phase of digestion, the vagus nerve suppresses somatostatins. Why? So digestion can proceed. As I mentioned before, octreotide is a synthetic analog of somatostatin. So somatostatin normally inhibits secretion of many hormones. Octreotide mimics that effect and lasts much longer in the body. Now, the key principle to remember here is that the octreotide suppresses hormone secretion from a lot of endocrine tumors. Now, what is VIPoma? This is a pancreatic neuroendocrine tumor that secretes vasointestinal peptide. Vasointestinal peptide normally causes massive intestinal water secretion, diarrhea, hypokalemia, and achloridria. So you have a classic VDHA syndrome where you have watery diarrhea, hypokalemia, and achloridria. How octreotide helps here, it inhibits this VIP release from the tumor and it reduces intestinal secretions. Result is that the diarrhea decreases, the potassium loss improves, and the fluid loss decreases. So octreotide basically controls the symptoms of the VI coma. Now, acromegaly is again a pituitary adenoma that produces excessive growth hormone. This growth hormone increases the IGF-1, and this causes enlarged hands, feet, coarse facial features, organ enlargement, and insulin resistance. So, somatostatin normally inhibits the growth hormone release, and that helps to suppress the growth hormone secretion. Then we have something called as the carcinoid syndrome. This is a neuroendocrine tumor again, often from the ileum that secretes serotonin and other vasoactive substances. Again, that leads to flushing, diarrhea, bronchospasm, and right-sided heart disease. Somatostatin or octreotide inhibits secretion of serotonin and other vasoactive peptides from the tumor. So result is mainly symptomatic treatment.